Um, Good morning, everyone. So today I will speak about echocardiographic features of systemic illnesses. And so my objectives will be to review the clinical presentation of systemic diseases involving the heart. Actually a case-based discussion of echocardiographic features of systemic illness. We'll have some clinical and some imaging approach to some systemic diseases involving heart. So it's all based on 6 cases that I have selected from our black book, and hopefully it will be useful. And I added some discussion about those cases. So what I'm going to do is that I'm going to start the case, and then if anyone wants to give a diagnosis through the chat, he's more than welcome. Okay, so we'll start the first case. So this is a 65-year-old gentleman who presented to emergency department due to a burn on his hand from cooking. During the emergency department visit, he also had an incidental finding of atrial flutter at rate of 120 beats per minute, but he was completely asymptomatic. He was prescribed metoprolol 12.5 milligram BID and aspirin, and he was referred to arrhythmia clinic. He presented to the clinic mentioning that he had no symptoms of palpitation, dizziness, short breath, or chest pain. He's able to perform his usual activities without restriction or limitation. And this is the ECG that he had during the emergency visit. And as you can appreciate, the sawtooth appearance of the, you can look at the tooth and the 3 and inverted V's suggested of atrial flutter with atrial rate around 300 and ventricular rate around almost 120. So his past medical history includes an upper GI bleed. His cardiac risk factors are non-contributory, meaning he denies any history of hypertension, diabetes, dyslipidemia, non-smoker, no history of alcohol abuse, and no family history of coronary artery disease or sudden cardiac death. He had no symptoms related to sleep apnea. His blood pressure was 130 over 96, heart rate is 100 beats per minute. He weighed 142 pounds, and his height is 163 centimeter tall. S1 and S2 is normal, no significant tremor noted, respiratory is clear, no crackles, noises. There was mild swelling of the ankles bilaterally. So his ECG documented an atrial flutter with variable AV conduction. Atrial rate is 300 beats per minute, ventricular rate is 101 beats per minute, no tooth pattern, no and AVF, and negative deflection of the F waves, they are flutter wave in P1, and it's likely an isthmus dependent atrial flutter. So blood work noted sodium of 129, potassium 4.3, chloride 99, glucose 5.7, creatinine is 72, WBC is 6, hemoglobin 135, and platelets 147. So apart from sodium, nothing significant. So now I will show the echo of this patient. Okay, so what you see in the left is actually the echo 10 years ago when the patient was so it was done for a suspected murmur at that time. I'm not sure why it's not playing continuously. It's a bit slow. Okay. And this is the echo on this presentation. Okay. So feel free to write whatever you think is the diagnosis in the chat box, and then I will go back to the echoes and explain them. Okay, so that's 10 years ago and that's now. Okay, next image. So 10 years ago and now when he presented with a flutter. So this is also an Arabica 4. And this is now. Okay, and this is an IVC, a non-collapsing dilated IVC. So let's go back. What do you think is the working diagnosis? Okay, Basma is answering. Thanks, Fizna. I think it was clear that this is a cardiac amyloidosis. So although this patient was asymptomatic, but let's go back and look at the features of cardiac amyloidosis here. So from the parasternal long axis view, you can appreciate firstly, uh, I think pericardial effusion is not well seen in this image, although it's well seen in other images. We can see it, look at it later on. Other features, left atrial enlargement. What is the striking is the thickening of the LV wall, and that's concentric wall thickening. It has a specific texture, which is called a sparkling pattern. Although it's non-specific, but it's really a striking pattern for myodosis. Other features which involve thickening of the mitral valve, which you can see here. Going to the next image, you can appreciate an LV wall thickening there and thickening of the mitral valve and some small pericardial effusion, trace pericardial effusion, which was seen also here. So this is an apical four-chamber view showing biventricular thickening here, or showing an RV thickening of the ventricular septum, and you can see also thickening of the interatrial septum here with dilated biatrial dilatation. So what's very important?
Please mute yourself if you're not speaking.
Okay, so going back, looking at diastolic function, which is a very important parameters in patients with amyloidosis. Unfortunately, this patient was in atrial flutter, so assessment was incomplete, but we can appreciate here that high E velocity, which is seen in this image. And then this is a very important feature that we have to add to all patients with amyloidosis, so the strain pattern. And what you can see is that an apical four-chamber view, where you see that the apex, which is colored here in pink and green, is spared, where basal segments are more affected. And you can see that also in the graph. On the three-chamber view, you can see it also again. Apex is spared, more basal segments. Also, this is in the two-chamber view, where you can see also the apex is spared and preserved of basal segments. And when you collect put this all together, you have what's called an apical sparing pattern, or a cherry on top feature of amyloidosis. So this patient, he underwent an MRI, and it showed a normal LV cavity with mild impairment of systolic function, elevated left ventricular mass index, concentric LV wall thickening with maximum end-diastolic wall thickening of 20 millimeter, widespread non-ischemic myocardial delayed enhancement throughout the left ventricle, diffusely elevated T1, non-convincing myocardial edema, and overall findings are highly suspicious for cardiac amyloidosis with a Kehl score, and that's a Kehl score, the score that's used to assess amyloidosis in MRI is 14, where any score more than 13 favors ATTR over AL type amyloidosis. However, MRI is non-specific in differentiating the types. The patient went and he underwent a pyrophosphate scan in another hospital, and it confirmed the diagnosis of ATTR amyloidosis. Within the investigation panel, he had a diaphragmal perfusion imaging study, and it did not reveal any ischemia. So what we had now is a 66-year-old gentleman with a diagnosis of ATTR amyloidosis. So he underwent a genetic test to complete the assessment, and he was positive for a PA1D variant of TTRG. And it's a must to do a serum light chain to rule out AL amyloidosis. So he had that, and it was negative. The patient was enrolled in the tafamidis trial, and he's still on the medication. So let's now talk about cardiac amyloidosis. So cardiac amyloidosis is a disease that results in restrictive cardiomyopathy. It's caused by extracellular deposition of proteins in the myocardium. The proteins have an unstable structure that causes them to misfold aggregate deposit as amyloid fibrils. What you see here is a histological specimen, and they used a stain called salvated alkyne blue. And what you can see, these in the white arrows, these blue are the amyloid fibril deposits within the myocardial cell. And this is a gross specimen showing LV also is hypertrophied, and you see LV and RV, left atrium is enlarged, and these white arrows point toward the amyloid deposition into the heart. The amyloid can be divided into two types, like to easy the understanding of the disease. So either a systemic amyloidosis type or trans-routine amyloidosis type. So the systemic amyloidosis type is divided into light chain, which usually we see with the plasma cell decreases, and those patients usually they have high light chain, and the organs that mainly affected are the kidneys, heart, and liver, with median survival of 1 to 3 years. The systemic amyloidosis type, which is seen in systemic illness and autoimmune and infectious, it's mainly a renal dysfunction, and it's usually median survival is 11 years. Where the transthyretin amyloidosis, it has two types. The mutated type, which is more familial form of the disease, and it's common in African American, and the median survival is 2 years. Where the wild type, which is previously called senile amyloidosis, seen more than 75-year-old people, and it has specific feature of carpal tunnel syndrome and male dominance, and the median survival is 4 to 6 years. So some clinical clues to the diagnosis of amyloidosis. So intolerance to antihypertensive or heart failure medication because of symptomatic hypertension or orthostasis, persistent low elevation in the serum troponin, a discordance between the QRS voltage on ECG and wall thickness on imaging, unexplained AV block or prayer pacemaker implantation, unexplained LV wall thickening, right ventricular thickening or atrial wall thickening, and family history of cardiomyopathy. Non-cardiac clues to the diagnosis include involvement of neurologic, so sensory-motor polyneuropathy, autonomic dysfunction in form of either orthostatic hypotension, postprandial diarrhea alternating with constipation, gastroparesis, urinary retention, and incontinence. Orthopedic manifestation like carpal tunnel syndrome, lumbar spine stenosis, unprovoked bicep tendon rupture, and hip and knee arthroplasty, and family history of polyneuropathy. These are all clues to the diagnosis of amyloidosis in any patient. So some features that differentiate types of amyloidosis clinically. So skin bruising and macroglossia is more with light chain amyloidosis, where deafness, bilateral carpal tunnel rupture, bicep tendon, lumbar spine stenosis, and vitreous deposits, and family history all suggestive of TTR amyloidosis. On the other hand, renal insufficiency, proteinuria is more of light chain amyloidosis. Clinically and from the cardiac wise, really, there is no difference really, and the clinical they presented all the same feature, with the ECG feature of pseudo infarct in ECG and low voltage to a degree of LV thickness and AV conduction, seen in both diseases. So looking at the echo of patient with amyloidosis, what we can appreciate what we already spoke about. So small pericardial effusion and concentric thickening of the myocardium with the texture, it's called refractile or sparkling texture, left atrial enlargement, and sometimes thickening of the valves, and thickening of the interatrial septum also can be seen on those kind of patients. Very important feature that to look at, especially in advanced amyloidosis, is what's called the 555 sign. And if you look at this tissue Doppler, you can see that this is 5 and this is 5. So S prime, E prime, and A prime less than 5. So 555, and so it's a sign for advanced amyloidosis when they have advanced restrictive disease. Also, another feature is the lengthening of isovolumic contraction time and isovolumic relaxation time with shortening of the ejection time. All these are signs of advanced amyloidosis. And again, the cherry on top or apical sparing pattern of amyloidosis seen in those kind of patients. So when reporting amyloidosis patient, suspected amyloidosis, there are specific parameters in echo that has to be and it's required for reporting. So you have to comment about LV wall thickness, so increased LV wall thickness more than 1.2 centimeter and increased relative wall thickness more than 0.42. And it's when it's really with an ECG that's low voltage, this is particularly suggestive of the disease. You have to comment about myocardial echogenicity, so increased echogenicity of the myocardium, what's called sparkling hyperrefractile texture of the myocardium. It's really not highly specific, but it has differential diagnosis of end-stage renal disease or other infiltrative cardiomyopathy. However, in conjunction with other findings, and especially the longitudinal function of the LV, it's highly suggestive. You have to comment about atrial enlargement and dysfunction. It's non-specific but important findings support the diagnosis and provide insight into risk of stroke or arterial embolism. You have to comment about the interatrial septum thickening and valve thickening, and especially if it's more than 0.5 centimeter. You have to comment about pericardial effusion, but it's non-specific when it's coupled with other findings suggestive of diagnosis. You have to do full diastolic function analysis with a grade 2 and worse diastolic function and high ER ratio more than 1.5 and reduced E deceleration time less than 150. So it's really helpful in determining even prognosis of those patients. Another thing is that severely reduced A-wave velocity can be due to LA failure, which can be helpful in determining also risk of stroke. You have to do estimation of the RV systolic pressure, PA pressure, and the right atrial pressure. And then tissue Doppler, as I mentioned, the 555 sign with all the tissue velocities less than 5 centimeter per second. And it's highly suggestive diagnosis and may not be sensitive, especially in the early disease where restriction did not happen. Strain pattern, as I mentioned, is very important. So decreased global longitudinal LV strain with values less than 15% is very characteristic of amyloidosis. And the bullseye, which with the cherry on the top sign, is also another feature that's very important for diagnosis of amyloidosis. So when reporting at the amyloidosis, so it's either the reporting will go into either of these three categories. So either not suggestive, when the normal LV thickness, normal LV mass, normal atrial size, septal or lateral tissue Doppler more than 10. So this is not suggestive of amyloidosis. Strongly suggestive when there is an increased LV wall thickness, increased LV mass, typical strain pattern, mitral annular less than 5, and biatrial enlargement, small A wave, especially in the patient with sinus rhythm, and small pericardial pleural effusion. Equivocal when the findings are not described above. And always provide looking into the previous echoes and provide a follow-up recommendation for those kind of patient. And maybe also add some suggestion to rule out AL amyloidosis and maybe refer the patient for further imaging modality like MRI or pyrophosphate scan. So approaching patient with amyloidosis usually starts with the history. So an ECG and echocardiogram. So any presentation that's suggestive of another diagnosis of infiltrative procedure, you should go directly to the CMR to rule out OCAM and other diseases. So, but if still there is a high suspicion of amyloidosis, then you should always do light chain and rule out light chain amyloidosis. And so what you do is the serum kappa lambda free light chain, and any disproportion of the ratio, either less than 0.26 or more than 1.65 is the diagnostic. And you have to do also serum and urine immunofixation. So presence of monoclonal proteins is abnormal. And then if that positive patient should be referred to hematology for further management. If not, then the patient should go to pyrophosphate if the pyrophosphate scintigraphy is available. And if it's diagnostic, then genetic testing has to be done to determine the genetic type of ATTR. If not, if the pyrophosphate is not available, then an endomyocardial biopsy is the next step with a positive congruent stain for amyloidosis. So when talking about when you have a confirmed case of ATTR amyloidosis, the management lies on actually three pillars. The first one is management of heart failure. So usually the standard heart failure therapies has not been shown to offer clinical benefit. Loop diuretics is very important symptomatic treatment. Management of arrhythmia is also is another important part of the management of those kind of patients. Like even our patient presented with an atrial flutter. So medical therapy with medication and even cardioversion. Um, One of the things that you should avoid is digoxin, since it's high toxic in those kind of patients and may bind to amyloid myofibrils. Anticoagulation is important for patients with atrial fibrillation and amyloidosis, and that's regardless of their CHA2DS2-VASc score. And device therapy also is important for this kind of patient in case they need it. So PPM for heart block, ICD in selected patient with VT or aborted sudden cardiac death, and CRTD in selected patient when they are really dependent, and that's going to help their heart failure symptoms. Disease modifying agents. Now, we are lucky to have some new treatments for amyloidosis. So I'll just speak first. So amyloidosis is pathophysiology that transretin is formed in the liver, and it's a carrier for the enzyme TSH and for the hormone TSH and other vitamin A enzymes. Hormones. So the TTR breaks apart and then it binds and forms amyloid fibril and then it deposits into the organs. So what those medication does, either they suppress the TTR or what's called by liver transplantation or TTR gene silencers, and we have two medication for that. Or we have also a TTR stabilization medication, which is the most famous one is the tafamidis. So it prevents the break of the TTR tetramer. And then you have a TTR disruption. So when you have the amyloid fibril, and these are the old medication like doxycycline and the monoclonal antibodies. So depending on the cardiac and neurological involvement, and depending on the genetic subtypes of ATTR amyloidosis, the decision to go with each treatment. So when you have an ATTR wild type cardiomyopathy, tafamidis is the drug approved for that, and an off-label use of other medication. When you have the mutation of familial type, so if there is a cardiomyopathy, tafamidis is the first drug of choice. Okay. Now we'll move to the next case. So again, feel free to give a diagnosis. Okay, so that's the first parasternal lung axis. Oh, let's see if anyone thinks. What do you think? Well, that's maybe a tough case. So let's go back. So what we notice from the parasternal long-axis view is that you see a concentric LV wall thickening, almost obliteration of the LV cavity during systole, and there is also a small pericardial effusion, also involvement of the RV with this thickening. But we can also, what we see here, the sparing of the basal posterolateral wall of the LV, and that's a suggestive of the diagnosis of actually fibrous disease. So looking at the apical four-chamber view, you can see also biventricular thickening, and you can see there is a pacemaker also lead, which point that the patient may have a conduction problems. There is MAC of the mitral valve, but that's not really a part of this disease. And again, what you can see is that sparing of the basal infralateral wall, and we'll speak about that when we talk about the strain pattern. Again, LV wall thickening. So looking at the diastolic parameters, almost the same features as any form of restrictive, severe restrictive cardiomyopathy. So you have an EA ratio more 0.8, you have medial E velocity of 2 and lateral E velocity of 4. Both are pointing toward diastolic dysfunction. So this is a 51-year-old male who was diagnosed with a kidney dysfunction in 2006 and he was placed on an intermittent hemodialysis. He underwent transplant in 2012, renal transplant. Along the way, he was diagnosed with Fabry disease, so involving both the heart and the kidneys, and he was started taking enzyme replacement therapy in 2007. He also had joint involvement, especially bilateral knees, shoulders, elbows, severe arthritis. He has also experienced diminished hearing, thought to be due to Fabry's involvement as well. His other medical problem is significant for dyslipidemia, so no history of diabetes, hypertension, MI, CVA, or TIA. So what's Fabry's disease? It's an X-linked lysosomal storage disorder. It's caused by mutation in the GLA gene, and it's leading to deficient alpha-galactosidase A activity and accumulation of glycosphingolipid material. And this is causing a life-threatening complication. And the phenotype of Fabry disease varies from the classic phenotype, which is usually seen in pediatric patients with multi-organ involvement, and to later onset predominantly cardiac phenotype. So I will not go through the classic Fabry disease because it's mostly seen in pediatric where they are presenting with neuropathic pain, pain crisis, some dermatological and even gastrointestinal manifestation, and renal also they can present with either proteinuria and going into CKD. What is seen as the late presentation of Fabry disease, which usually involve either the heart, the neural system, and the renal system. So patient will have cardiomyopathy, hypertrophic cardiomyopathy with concentric hypertrophy, and minimal or absent outflow tract obstruction, unlike HOCM, for example, and reduced exercise tolerance, syncope, cardiac fibrosis, heart failure, bradycardia, chronotropic incompetence, and they may present also with atrial fibrillation, VT, and sudden cardiac death. ECG findings in those patients with shortened PR interval in early stage T-wave inversion and the presence of LVH signs. Also, they have vascular, so aortic stiffness, TIA, and strokes. So this is the strain pattern difference between the let's 3 examples of strain pattern. So the first one is what we have seen before, which is amyloidosis with the apical sparing pattern, as you can see. In Fabry disease, what we can see is really a characteristic preferential reduction in the infralateral segment. So what you can see here is that the infralateral segment is the area that's usually first fibrosed in those patients, and so it's mostly affected by the disease. And as we have seen in the previous images where there was thinning and scarring of the infralateral, so it was spared from hypertrophy, but it was more fibrosed segments. And then we have also the apical HOCM, where you have sparing of the and as a sparing of the basal segment, and so it's a reverse form of apical sparing. Okay, so the testing is to diagnose Fabry disease is for a male patient because it's an X-linked. So alpha galactose A activity testing is diagnostic for male patient. Sometimes genetic testing is needed to either establish the disease phenotype, rule out benign polymorphism that cause reduced level of alpha galactose activity, and also it permits the testing of at-risk family members. For a female patient, you have to demonstrate the presence of disease-causing mutation, since plasma level of the enzyme is often found to be normal range. However, leukocyte alpha-galactose activity may be low. And recommendation follow-up for those kind of patients is that, especially cardiac, so they have to have blood pressure and cardiac rhythm annually, ECG and echocardiography annually, and 48 hours Holter monitor to detect heart rhythm. It should be done annually. And recommendation for initiation of enzyme replacement therapy for classic Fabry disease, any male patient should be started on treatment, where a female patient, either if they are symptomatic, so starting treatment, if they are asymptomatic, if they should be starting enzyme replacement therapy when there is an objective evidence of a disease, either as a laboratory, histological, or imaging evidence of a disease. For late onset Fabry disease, both male and female, you start with enzyme replacement therapy whenever you confirm the diagnosis. Other medications, so consider an ACE or ARB in those kind of patients for cardiac disease. Beta blockers should be used with caution, and amiodarone should be avoided. Amiodarone is known to have interference with the enzyme replacement therapy, so it should be avoided in those kinds of patients. And of course, if symptomatic bradycardia or chronic thrombolic incompetence, a permanent pacemaker may be needed. If evidence of atrial fibrillation, anticoagulation also needed, regardless of their CHA2DS score. And if there is an evidence of strong suspicion of malignant arrhythmia, consider an ICU. Let's go now to the third case. So a 53-year-old transferred to our hospital from another hospital after experiencing 8 days of acute peripheral edema and short breath on exertion. He had no chest pain or palpitation. He had previous episode of short breath, but this was attributed to asthma. A transthoracic echo done at referral hospital showed an LVF of 15 to 20% pericardial effusion. So he was admitted for investigation. So the investigation to determine the cause of his cardiomyopathy, infectious workup, including P, C, HIV, and blood cultures are all within normal, negative. Autoimmune workup also was done, showed negative ANA, rheumatoid factor, anti-double strand DNA. ANCA was reported as atypical pattern and was sent for further analysis. He had a coronary angiogram which showed no lesion in the left main and no lesion in the left LAD or other vessels. So normal coronary angio. So this was his echo when he presented. As you can see, there is pericardial effusion, at least moderate pericardial effusion. There is impaired LV function, and also there is a left atrial enlargement. And this was in, let's look at it. So parasternal short axis at the level of the aortic valve, and this is the pulmonary valve. And what we can appreciate is, I don't know, it's not playing, is there was a more independent mobile mass on the pulmonary valve. Hopefully it will play. Okay, so looking at the apical views, you can see that there is an impaired LV function, dilated LV, and what you can see here is that there is a mural thrombus, so overlying the whole apex. Okay. So zoomed view on the apex here in the 3-chamber view, and you can see clearly that This thrombus is overlying the whole apex there. So it's also in the apical too. Okay. So what do you think? Let's see if anyone wants to contribute. Okay. So just to save time, so this patient, he was noted to have slightly elevated eosinophil count of 0.8 to 1 persistently. So the hematology service was consulted and for consideration of hypereosinophilic syndrome causing his cardiomyopathy. So he underwent a bone marrow aspirate and mild marrow. The result was mild marrow eosinophilia, no evidence of lymphoproliferative disorder, which is very important to rule out malignant hematological disease when you have an eosinophilia. Okay, so he underwent an MRI cardiac and it showed mildly dilated LV, severe impairment of systolic function, normal size RV with moderate impairment of systolic function. There was a widespread subendocardial scar and myocardial edema, and there was an RVOT mass, which we have seen in the echo, and there is a small LV apical neurothrombus and large pericardial effusion. And there suggesting that these appearances are strongly suspicious for eosinophilic myocarditis and lobular endocarditis of the pulmonary valve. So after long discussion with the patient and reviewing all of his investigation MRI, he was started on treatment with oral steroids at 65 milligram daily. Also, he was started on warfarin anticoagulation after heparin bridge. So echo was repeated 1 month after the starting of steroids and anticoagulation. So as you can see, the LV function is almost back to normal, and the pericardial effusion now is very small, like almost trace pericardial effusion, and that's just only after 1 month of starting steroids. Looking at the VOT, you can see that the mass is not there anymore, and the pulmonary valve is normal. So, looking at the apex also, the LV, okay, so no more apical thrombus and multi-views, and LV function is almost back to normal. So, in the word of the primary physician who's taking care of this patient, he said this has been a truly amazing case. His ejection fraction has gone almost back to normal as a result of steroid administration, and the clots in the left ventricle and the pulmonary outflow tract are now gone. I'm delighted with this miraculous recovery. This is just simply wonderful. Okay, so let's talk about eosinophilic cardiomyopathy. So a hypereosinophilic syndrome is characterized by presence of marked unexplained blood and tissue eosinophilia associated with variety of clinical manifestations. The definition of eosinophilic myocarditis is really an old definition, and it has three criteria. So blood eosinophilia more than 1,500 longer than 6 months, or death before 6 months, lack of evidence for parasitic, allergic, or other known cause of eosinophilia, and presumptive diagnosis of organ involvement. So more than 1,500 and no other evidence for other disease, and you have to have an organ involvement. And the limitation of this definition is really something that's discussed in most of the papers about hypereosinophilic syndrome. So the first criticism is that it requires 6 months of therapy. So it's unlikely that a patient with symptomatic hypereosinophilic syndrome would remain untreated for 6 months, given the availability of treatment that can reduce eosinophilia before irreversible damage. And then it requires the threshold of 1,500, which is not seen in a lot of patients with hypereosinophilic syndrome. So For example, a patient with disorders like eosinophilic pneumonia, eosinophilic associated gastrointestinal disorder, or Chebbi-Strauss, they may fulfill all the hypereosinophilic syndrome criteria except for the level of 1,500. On the other hand, some patients they have level of more than blood eosinophilia more than 1,500, but they do not exhibit any signs of eosinophilic mediated organ damage. So the definition should always involve a tissue. So either blood eosinophilic count more than 1,500 or a tissue eosinophilic considered by a pathologist. So doing a biopsy and looking for eosinophilia. It has three phases. So stage one, which is an acute necrotic stage of hypereosinophilic syndrome, and it usually starts in the 5 to 6 weeks of the disease, and it usually involves the subendocardium and myocardial infiltration with necrosis. It involves both ventricles, so and it sometimes is asymptomatic. But if it's symptomatic, it can present with acute necrotizing myocarditis. So sometimes even mimicking ACS, and rarely it can present with a tamponade. And the clues to this in transthoracic echo is increased subendocardial echogenicity, wall thickening, and regional wall motion abnormality with pericardial effusion. MRI will show edema, no fibrosis, and endomyocardial biopsy will show the presence of eosinophils with positive staining for eosinophil granule protein. The second stage, which I think our patient is in, is the thrombotic stage, where it's usually in around 10 months of the disease, and it has mural thrombus formation. It involves both ventricles with LV more than RV. It has apical thrombotic occlusion, also common, valvular and subvalvular thickening and tethering with fibrothrombotic material, and valve vegetation. The outflow tract, which is unlike our patient, is less commonly involved, and it can present also patient can present with an embolism and in some cases with heart failure. And transthoracic echo using contrast shows thrombus. MRI will show endomyocardial involvement and intracardiac mass, like our patient. And myocardial biopsy is hazardous during this due to risk of thromboembolic risk. The last stage, which is a late stage in around 24 months of disease, is the fibrotic stage, where patients present with restrictive physiology, and sometimes they have fibrosed chordiotendyny, maybe calcified papillary muscles, and they present with heart failure and arrhythmia disorders. A transthoracic echo will only show restrictive physiology, where MRI usually showed endomyocardial fibrosis. Biopsy will show fibrosis, but eosinophils will not be seen in those kinds of patients. So, important point to consider when talking about hypereosinophilia syndrome is the myocardial damage predominantly affects the subendocardial tissue. So, whenever you have an increased subendocardial echogenicity, it should raise attention of hypereosinophilic syndrome. A combination of LV dysfunction and intracardiac thrombus can be seen also prior to development of fibrosis. Thrombi are usually located in the apex or subvalvular region of the AV valve, while the outflow tract are generally spared. And in later stages, thrombi can organize as intraventricular or valvular vegetation. It's called the Loeffler endocarditis. And valvular damage is common and may be the consequence of fibrotic valvular thickening or impaired mobility of the apparatus, especially in the fibrosed stage. So always in early disease, MRI is very helpful. If you have a typical lesion, then you should start treatment for hypereosinophilic syndrome before other stages happen. Always start anticoagulation if you have thrombosis. Treat as any heart failure patient if you have either systolic or diastolic dysfunction. So this is the last case. So I'll just go ahead and talk about this case. So this is an parasternal RV inflow image. And what you can see here is the tricuspid valve. What's striking about this tricuspid valve is the thickening of the tricuspid leaflets. They look retracted and they look immobile and they are in semi-open position with large coarctation gap. Again, you can see that in the apical four-chamber view. So what we appreciate here is the severe TR, almost torrential TR with wide vena contracta. The hepatic veins shows a systolic flow reversal, which is a sign of significant TR, and this is the Doppler signal from the TR showing that a triangular shape of severe TR with high density. Again, this patient had another feature of pulmonary valve thickening, as you can see. So the pulmonary valve looked thickened and with restricted opening, and some mild pulmonary stenosis. So this is a case of carcinoid syndrome. So this is a 59-year-old woman. She presented to ER in September 2021 with acute onset of pelvic and back pain. She stated that she had back pain starting in mid-July. However, she was taking care of her mother, who was sick, and attributed the back pain to bald muscle. Band CT showed mediastinal lymphadenopathy with left supraclavicular lymphadenopathy, retroperitoneal lymphadenopathy, mesenteric mass, ascites, peritoneal disease, and very congested liver. Her CA 125 was high, CA 99 was 29, and the CA biomarkers was normal. So she had the biopsy, and the biopsy showed well-differentiated grade 2 neuroendocrine tumor, and the Chi6740 visit. The Chi67 is an antigen that's used to assess for cell proliferation. A PET scan showed extensive disease in the lymph node, peritoneal, mesentery, and Crockenberg tumor, which is a tumor in the ovarian area that's metastasized mostly from GI. And the primary origin of this endocrine tumor is most likely the cecum or the appendix. She underwent surgery, and this is the debulking surgery to reduce the burden of the tumor. So she had bilateral ovarectomy for massive Crockenberg tumor. She had small bowel resection, and she had resection of the cystic mesenteric mass, cystectomy, appendectomy, omentectomy, and so full debulking of the tumor just to reduce the load of this tumor in this patient. So carcinoid syndrome is a neuroendocrine tumor. It's relatively rare. The incidence rate is around 2.5 to 5 cases per 100,000. Mostly the source of the carcinoid tumor most of the times is from gastrointestinal tract, in particular from the proximal part of the colon and the distal part of the small intestine. It's predominantly demonstrate indolent disease biology for many years, and it becomes symptomatic when they are large enough or they metastasize to the liver, lung, bone, or other sites. The pathophysiology is not entirely known. The sign and symptoms of the disease, so there are symptoms that are related to the carcinoid syndrome, which are bronchospasm, cyanosis, sometimes diarrhea and flushing, hypotension. Carcinoid heart disease symptoms are similar to right-sided heart failure, so ascites, dyspnea, fatigue, peripheral edema, and presence of pleural effusion. Involvement of the heart, so echocardiographic feature of the carcinoid syndrome are involvement with tricuspid valve with thickening of the valve leaflet and subvalve apparatus, diminished normal concave curvature of the leaflet, altered dynamic motion of the leaflet during diastole, fused and shortened chordae, retraction, and reduced excursion of valve leaflets. Pulmonary valve also may be involved in this kind of patient, and it's present with diffusely thickening valve cusp, straightening of the cusp, and fixed retracting and thickening of the cusps, with either pulmonary regurg or pulmonary stenosis. Right ventricle is usually dilated with impaired function in those kind of patients. Very important point that appearance of thickened retracted tricuspid valve is pathognomonic, but you have to rule out that the patient had an exposure to some appetite suppressant, fenfluramine, or an ergot derivative dopamine agonist, which can give similar uh, feature. And left side also can be involved in those kinds of patients. The reason that serotonin is thought to be inactivated as it passes through the lung. So involvement of the left side either is due to presence of patent foramen ovale with right to left shunt, or presence of bronchial carcinode, or high level of circulating vasoactive substance that the lung cannot clear anymore. Small pericardial effusion is present in around 10% of the patient, and sometimes in rarely patient can have myocardial metastasis from the primary tumor. I'll just go through these cases quickly. So this is a patient who had anterior wall thickening, as you can see, anterior RV wall thickening. Again, clear RV wall thickening in those kind of patients. So thickening of the RV wall, as you can see, this is at the level of mitral valve and level of the aortic valve. So this is a lady who had grade 2, grade 3B follicular lymphoma with involvement of the pericardium. She had an R-CHOP chemotherapy after finding this, and follow-up echo almost 3 months after the starting with chemotherapy showed marked reduction of the anterior RV wall mass, and the pericardial effusion has disappeared. You can see here. Another case, as you can see, there is a big mass on the right ventricle, and that mass is heterogeneous mass. It's occupying almost the whole RV outflow. As you can see, this is a sweep. And when giving contrast, this mass seems to be getting some contrast, which means that it may be partially vascularized mass. So this is a case of patient who had femur osteosarcoma with mets to the heart. Unfortunately, she underwent urgent resection of the mass. She was followed by 6 cycles of adjuvant chemotherapy, and she's doing well now, almost 6 months post-surgery. Thank you.